Good afternoon, everyone. My name is Joe Pyle. I'm with the Thomas Scattergood Behavioral Health Foundation, and I want to thank you all for joining today's webinar in the Think Bigger, Do Good Policy series. Today's paper is entitled COVID-19, Structural Racism and Mental Health Inequities, Policy Implications for an Emerging Syndemic. Some general housekeeping for today's webinar. The webinar is being recorded. We have muted all of the participants, and we ask that you direct your questions to the Q&A function, and we're hoping for about a 30-minute Q&A discussion today. And that post-webinar, we will be providing a recording and the Q&A text file to all participants. I wanted to take a minute to give a brief history of the Think Bigger, Do Good policy series. This series started over 4 years ago amongst 4 foundations interested in playing a larger role in mental health and substance use disorder policy and advocacy at a federal, state, and local level. To date, we have over 20 papers on topics ranging of the intersection of criminal justice, housing, harm reduction, suicide, and crisis services. This work would not be possible if it were not our partners at the F.A.P.A Foundation, the Patrick P. Lee Foundation, the Tower Foundation, and our partnership with Psychiatric Services Journal. I also need to thank 2 individuals, Howard Goldman, who is our editor, our mentor, and our friend on this work, and Allie Ferguson at the Scattergood Foundation, who without her leadership, this could not happen. Before we get started, I wanted to take a brief minute here and introduce our 2 speakers. Dr. Ruth Shim is the Luke and Grace Kim Professor of Cultural Psychiatry and the Director of Cultural Psychiatry at the University of California, Davis. Dr. Shim has been an outspoken advocate about the role of organized psychiatry and its perpetuation of racism. And she brings a unique perspective to this work as a board member of the Robert Wood Johnson Foundation. Dr. Stephen Starks is a professor at the University of Houston Medical School, and he has been directly involved in federal legislative process as a health and aging policy fellow. Both Dr. Shim and Dr. Sparks have been tireless advocates for understanding the cultural and social effects of mental health conditions and substance use disorders on patients, families, and their communities. They have been advocates for the integration of mental health into broader healthcare and the use of a systems approach to solving the crisis of COVID, racism, and mental health inequities. Before I turn the discussion over to Dr. Shim and Dr. Starks, recently I've been reflecting on the deaths of Daniel Prude and Walter Wallace at the hands of police. And their deaths are directly a result of the longstanding practices of the criminalization of mental illness and substance use disorder, white supremacy, and structural racism in our behavioral health and healthcare systems. And I have wondered, would the outcomes have been different for these 2 men if we had taken a more systems approach to solving the crisis that they were met with that morning and that afternoon? And so I'm going to start off my first question to Dr. Shim and Dr. Starks with this question of, what is a syndemic and how does syndemic theory apply to COVID, racism, and behavioral health inequities? And I look forward to this conversation, and thank you for being here today.
So thank you so much, Joe, for that introduction. And I and Dr. Starks are both really pleased to be here joining all of you for this timely and relevant talk. So I think to answer your question, Joe, about what a syndemic is, we can think about it as a concept that was developed by an anthropologist by the name of Meryl Singer. And Meryl Singer was the first to describe what a syndemic was. He described it as the concentration and deleterious interaction of two or more disease or other health conditions in a population, especially as a consequence of social inequity and the unjust exercise of power. And he went on to say that in syndemics, the interaction of diseases or other health problems commonly arises because of adverse social conditions that put devalued groups at heightened risk. And so what we see with the syndemic of the COVID-19 pandemic, structural racism, which has been been epidemic since the founding of this country, and mental health inequities, which is another condition that we see this synergistic effect in which these social conditions and disease conditions are all part of the way that devalued groups experience heightened risk and a synergy of negative consequences. And so in syndemic theory, individual epidemics are sustained in a community or population because of harmful social conditions and injurious social connections. And so if we are going to try to think about how are we going to address these conditions, we have to consider the fact that syndemics include epidemics both of the disease and the social conditions that contribute to the proliferation of those diseases. So the idea is that our status quo is to think about trying to address these conditions on a individual basis, or to take one condition, COVID-19, for example, and address that without the context of the other conditions, without recognizing that we have to consider how these conditions all interact with each other if we're going to intervene in a way that actually makes change. And so with that syndemic theory approach, with this idea that we have to address both social conditions, power differentials, social injustice, as well as the disease state itself, Dr. Starks and I have 8 policy recommendations that we put forth in the paper. And they are to protect essential workers and other vulnerable populations, to engage and empower communities, to optimize community-led crisis response interventions, to improve data collection and dissemination, to support school-based interventions, to expand financial support for mental health service delivery, to expand insurance coverage and insurance access, and to promote workforce diversity. And so with that, I will kind of turn it back to you, Joe, to further frame this discussion.
Sure. Thank you for that. And maybe we can keep those slides up there for a bit so people can kind of settle in with them. You mentioned right out of the gate this question of leadership and power. And I wonder if you and Stephen could talk briefly about, when we think about leadership, we think about COVID in its isolated form. We know that the federal response has not been what it needs to be for Black, Indigenous people of color. And I wonder if you could talk a little bit about how we shift that power dynamic, how you would see that happening, and where we all might come together to move the work ahead.
Yeah, thank you for that question. And again, looking forward to this conversation. And one reason why we wanted to frame it, I know the word syndemic itself might be a new term for many, is I know we're 13 months into this public health crisis. I think if we go back to the very beginning, if we think back to February, March, April, there tended to be an oversimplification of the impact of COVID-19 on racialized minority groups. So you often heard in the press and through some politicians just specifically about the disproportionate impact and the number of cases and number of COVID deaths in Black, Hispanic, Latinx, and Indigenous communities. And oftentimes that tended to point to or infer to some sort of racial inferiority. So it was just the fact that you were Black that you were being diagnosed with COVID-19. And when you have it framed that way in the press, that does a number of different things. So one is it impacts the community itself. And many communities of colors found that sort of framing as very stigmatizing for those groups. And again, if you also frame it in that regard, the policies that you institute, again, will be misdirected and won't really land easily. And so we saw that with policies kind of tied to contact tracing, access to COVID testing, wearing of facial masks and other coverings, and discussions about policies tied to physical and social distancing. The fact that we're using the term syndemics is important, again, for us to bring together those different aspects of pre-existing health conditions, of the impact of COVID-19, and really to kind of touch upon racism and economic vulnerability in those populations. And so as we thought about kind of whittling down and really thinking about the most important points and policies to work on, we wanted again to touch upon those key areas. We started with kind of thinking about our essential workers. And again, there were a lot of discussions about the number of persons of color who are in fact essential workers and don't have the luxury of not working, not taking public transportation, and not really helping to support their families' financial needs. Ruth, I wonder if you can talk to us a little bit more. I know we have in quotes here for our first policy point, the term vulnerable. So what does that mean when we say or use the word vulnerable when we talk about certain populations and communities of color?
Yeah, it's funny because we've used this term vulnerable, we've used other terms. In fact, terminology is challenging, and I think we can talk more about the challenges of the ways in which we use language. But in the past, I think vulnerable populations has been one way to kind of identify why some groups, why some populations have poor outcomes, why some populations have these disparities and inequities that we see. And so, it is a little bit tongue-in-cheek to talk about vulnerable populations, because what I think we really mean, what you and I meant by that concept, is really oppressed populations, and populations that have been systemically oppressed, marginalized, and had power removed from them. And so what you see is that whenever there is a population or a group of people that has been consistently and persistently oppressed and marginalized, then you start to see the emergence of the syndemic. You start to see the collection of negative outcomes, the collection of negative health outcomes in that population. And so if we're going to take a syndemic theory approach to try to address the problems that we see in vulnerable populations, in highly oppressed populations, we actually have to start by breaking down the structural forces that are creating the oppression. And it just so happens that two of the most highly oppressed populations in our society are people with mental health problems and substance use disorders, as well as people from minoritized communities, particularly Black, Latinx, and Indigenous populations. And so the synergy of those groups that are oppressed and the intersectionality of those groups leads those groups to commonly be vulnerable. So when we're talking about vulnerable populations, we're really saying people of color with serious mental illness and substance use disorders, and that we have to again consider that approach from a much more complex contextual lens than the lens that we've been using, where we kind of individually tackle these things. So Steve, it's really interesting because you talked about kind of the early ways in which in the pandemic people kind of had just a very narrow lens. And you know, my favorite example of this, unfortunately, was Surgeon General Adams, who, you know, got up in front of everyone in a press briefing and said, you know, you have to do this for your abuela and for your big mama. And this idea that people who were people of color, Black people and Latinx people who were contracting COVID at higher rates, were doing so because they were making poor decisions, or because they were exposing themselves to COVID recklessly, rather than recognizing that those populations that have been oppressed often have to go to work in conditions in which there was no protection for them from COVID. They are not able to work from home. Oftentimes they have to be in settings and situations in which their exposure is the very nature of trying to survive and live in the country. Is the thing that is creating the exposure, not a poor decision or a bad choice.
Yeah, and I think when you talk about that, other thing I think about too is the other impact of other policies in other arenas. So economic policies, housing policies, policies kind of aligned with our criminal legal system, again, that makes certain populations vulnerable. And we see that in terms of COVID risk and exposure in jails and prisons, where Hispanic, Latinx, and African-American men are disproportionately kind of impacted in those situations, or also in certain long-term care facilities and other settings, other housing settings, or just in terms of certain communities where there is kind of densely populations and densely packed communities that don't have kind of adequate public health resources and support. And I know we're talking about policies kind of broadly. I sort of like to sometimes bring it back to people, because policies are in fact about people. And so I started to think about my own personal experience, and maybe you can share for yourself when it kind of hit home for you as a thought leader in social justice issues, as a researcher and someone who investigates and studies health equity. When were you concerned about the health impacts on the communities that you advocate for? For me, that personally hit home. I'm a native New Orleanian, and as many may recall, back in March and April, that started to be one of the early kind of epicenters. So they were in the highest kind of per capita rates of infection throughout the New Orleans metropolitan area, partly due to a large super spreader event that we typically have annually, Mardi Gras. And so my dad was still there living independently in his home, and I won't tell his age because I know sometimes he gets a little bit bashful. There he is alone and needing more supports and services, actually receiving some in-home care. And so at the middle of March, as those numbers started to tick up there, and I started to be a little bit more concerned about the local response, the local public health response, which again tends to be a disconnect and not really understanding the needs of our communities. Quite concerned, and we, as he likes to say, we kind of kidnapped him and brought him over. So it was that, as that growing number of in cities like New Orleans, Detroit, Brooklyn, Laredo, El Paso, LA County, our Dene people of our Navajo Nation, we start to see this trend across the country in these communities. And again, this question and concern about kind of how do we really best engage with them. And then for me, it was later on in April when I finally did get that first call from a family member about their loved one who was in a long-term care facility in a parish in New Orleans, who was admitted to the ICU with COVID-19. Their father was one of several members of a cluster, nursing home cluster, early on in April, where I think at least a dozen of those residents died from COVID-19. So again, when we think about connecting our policies to people, to these communities, again, just important to keep that syndemic theory framework kind of surrounding it. When we do talk about kind of engaging and empowering communities, Ruth, what is the best way for policymakers to think about and to really connect with ways to reach people at the community level. Often there's this top-down approach. Again, if the top federal government, the state governments don't really know and understand some of the complexities that happen at a community level, how can we kind of cause that to shift and kind of to really kind of partner with communities rather than just kind of distribute and disseminate information that may not truly kind of connect with their needs.
I think that's a great question, Stephen, and it actually gets back to Joe's question a while back around leadership. So I think it is really important for us to think about how to engage and empower communities. And you know, in this list of recommendations, the empowering of communities, you know, I think you and I see this as one of the most critical pieces of how to think in a syndemic theory about how to address these policy implications. The reason is because, you know, I think the more that we do this work, the more that we understand, again, how oppression works, the more we also understand that answers come from communities that are highly engaged and highly empowered to affect change in their local settings. Because there are many people that are on the ground that know what the issues are. There are people are the experts of their own experience, and communities are the experts of their own experience too. What we see oftentimes is that communities are systematically disempowered or systematically oppressed. So you know, we talk about this in the paper. It could be because of things like voter suppression. It could be because of gerrymandering. It could be because of a number of policies in which people who have power make decisions in order to maintain and support that power. And so as a result, because there's this kind of policy level power jockeying that happens, communities are often left out of being able to take control and make decisions to improve outcomes and to provide needed solutions. So the work then has to be making sure that that power is redistributed to communities, but also making sure that the systems that we have in place, including the structurally racist systems that we have in place that keep those communities from properly representing themselves in government, in all levels of the government, whether that be federal, local, or state. We have to be able to think about how the impact has to be on shifting policies so that representation is more effective. And I would just add that it really requires a combination of leaders who care about these issues and recognize and understand oppression, understand marginalization, understand social injustice, working to make sure that imbalance of power is redistributed, working in conjunction with communities that already hold that power. I feel like Joe wants to say something.
Well, one, could you put you back? You're controlling the screen right now. Do you want to take that slide down so people can see you and Stephen more clearly? That would be great. And I want to build on what you're talking about and ask a fairly broad question that you both can riff off of. When we were preparing for this, we had a conversation about, you know, there's a lot of focus on social determinants. And, you know, as part of the conversation, we were talking about how do we intervene upstream? You know, there's a lot of conversation about in the moment, let's talk about social determinants. But, you know, I think that the work you all are doing has implications before we get there. So I don't know if you could, you know, take a minute to talk about that. And maybe at the same time, which I think is a powerful statement you made earlier, it's really unpacking the social conditions from the disease state. And I think that, you know, maybe you could weave those two topics together and riff on that. And then we're starting to get some questions from the audience, which I'll bring in.
Yeah, and I'll you know, just share a couple of thoughts and then pass it over to Stephen. But I don't think you can actually tease out the social condition from the, I don't know if you can unpack those two things. I think that those two things are intimately intertwined. And therefore, the intervention has to be considering all of those things. And that's really what the social determinants of health and mental health is saying. It is saying that the things that drive disease in this country, the things that drive poor health, and the things that drive health inequities are in fact the social and economic conditions in our society. And most importantly, that those conditions were created by all of us, by the policies that we have enacted, and how those policies have advantaged certain groups and disadvantaged certain groups. So then, I love the idea of thinking about social determinants of mental health, and it fits in perfectly with syndemics, but I'm also starting to understand that it's actually not enough to just talk about social determinants of health, because what's really driving the development of the social determinants is the social injustice, and that's the laws and the policies that we pass in our country and in our society. But it's also the ideas and the beliefs that we have about populations. And this gets back to the white supremacy and the structural racism from the beginning. We have social norms in our society in which we believe that people of color are less than, are deserving of less, are deserving of more disadvantages in society, and should not be getting the same benefits or the same advantages as other people. And because of that fundamental belief system that we have, we then go on to pass laws and create policies that reflect those values. So then the interventions, and again, we have those same beliefs about people with serious mental illness and people with substance use disorders. We think that they are less than as well. And again, our laws, excuse me, specifically our laws around policies, our laws around treatment, our laws around access to mental health services, our laws about how we criminalize mental illness and substance use disorders, the policies we've put in place for how to manage crises that are mental health crises. All of these things are a reflection of our values and the policies that we create to address those things. And so if we're going to be serious about affecting the social determinants of mental health, we actually have to be serious about changing the policies and changing the belief systems that we have around who is worthy and who is deserving in our country.
And I think it's so important to keep that connection together. I think that's something that we often forget in my own kind of research about tied to health policies. We have to understand specifically those policies as it relates to those BIPOC communities that we discussed, has been tied to the civil rights kind of movement, has been tied to efforts for civil liberties. So when we talk about the Civil Rights Act, and we talk about the Social Security amendments that led to Medicare and Medicaid, which desegregated hospitals, when we talk about kind of the policies that have been kind of discussed in the Surgeon General reports, specifically the 2001 Surgeon General report that discussed mental health, race, and culture, or when we talk about the Affordable Care Act and its efforts and initiatives to truly achieve health equity in our country. Again, that theme has always been connected. We try to separate those in terms of a concept because it's easier and sometimes it's hard to address. So it feels like it's difficult and a challenge to address multiple issues, but recognizing that those efforts for civil rights and civil liberties movements did or have kind of resulted in the changes in health that we've had to this far, and will likely kind of continue to advance those issues as we, again, are continuing that journey to really achieve and propel health equity.
So one question, and then I'm going to turn it over to some of the questions that are coming in. That, this notion of, how are we better? How am I better at sharing power? I think comes up. And, one of the things that we talk, there's a lot of attention to the language of the issues that we're discussing here. And I think that the struggle for me is, how do I get the language right, but also how do I internalize the process? How do I actuate that language into action? And I wonder if you could talk a little bit about the role that language plays in moving the ball ahead on these issues, and this notion of how do we internalize change? Like, what can we be doing individually? It's easy to, I think we talked a little bit about the them versus us and ourselves. And, I would hope you could kind of, bring it to a ourselves level. Like, what can we be doing ourselves to aid in this journey?
Yeah, I think that the language situation is challenging because when I think about why we kind of run into challenges, and if you think about mental illness and substance use disorders, or maybe I should say behavioral health conditions, there's all these kind of minefields around language when we talk about mental illness and substance use disorders. And there's also minefields around language when we talk about race, when we talk about minority groups or versus minoritized groups, or whether we say BIPOC, or whether we say African American, or whether we say Black, or whether we say Hispanic or Latinx or Latina or Latino. I think, or whether we say Native American or American Indian or Indigenous. I mean, I think that these language issues come up over and over and over again. And I think why they come up over and over again has to do with power. I think it is communities and others trying to assert and trying to take power by taking power in names, in language. And so I think that it is going to continually be an issue forever, that when groups are oppressed and they are trying to regain power, part of that has to do with, what do I call myself? How do I identify myself? And how do I ask that others identify me? So then I think for people of privilege, or people that are in positions of power, it becomes very frustrating for those people sometimes, myself included, to move at what feels like the whims of people with less power saying that we should behave in a certain way. For example, I have several colleagues that really struggle around pronouns, and whether or not to kind of identify with pronouns. And I think there are people that will say, this is just too much. Like, I can't be bothered constantly changing my language, constantly trying to say these different things. But I think that the reason why it's important for us people, those of us that have power and privilege, to make efforts in this space is because it helps to acknowledge people attempting to define themselves for themselves, or as Audre Lorde says. So I think that people are afraid to say the wrong thing. We have this kind of cancel culture mentality, and so people don't want to say the wrong thing. But I do think that the idea needs to be acknowledged that we make an effort to attempt to address people in the ways that they particularly prefer to be addressed. And I think that's kind of all that we can be asked to do, and also recognize that we're not going to be 100% correct on this. The concept of culture of humility tells us that this is a lifelong process. And so we all have to kind of commit to, we are going to make mistakes and we're going to grow from those mistakes, and it's okay. I think the last thing I want to say about this is that what it sometimes does, what language sometimes does for people in power, is it shuts people down because they worry about making a mistake, or they worry about saying the wrong thing. And then they close off the idea of dialogue. They close off the idea of moving forward for fear of exposing themselves. I think this is particularly an issue for white people when talking about racism and talking about structural racism. And so there's a fear that you're going to say the wrong thing or do the wrong thing. And so it prevents meaningful dialogue that really is what we need to advance the situation. So I think we all have to be more fearless.
Well, I know that before I let Stephen, I know I struggle with that fear, so I'll work on being more fearless there. So thank you, Ruth. Stephen, do you want to?
Yeah, I just wanted to take a swing at that slant on the us versus them, and really touch upon the power dynamic that Ruth mentioned. And I think something that I'm mindful of, I try to sometimes remove myself from that us versus them conversation and remind myself that if it happens to them, it could happen to us. And so again, that we're interconnected and all of a part of it. And so when we talk, as we do and talk about some of our policies kind of tied to crisis response in terms of interventions, kind of moving and shifting from policing to other more appropriate mental health crisis responses for individuals. If those harms can happen to one community, they can happen to another. The other aspects of it is that if we are looking and viewing looking at those communities who have been made vulnerable or who have been marginalized by larger society, is recognizing that when they do better, we also do better. So all the many successes that we've had in terms of social justice movement, civil rights movement, have actually benefited all. So the initial target and the initial impetus may have been on certain communities, but I think there has been collective growth in all areas. So a lot of issues, obviously, specifically in the civil rights movement that have been tied to race, again, help to advance and propel issues pertaining to women's rights or LGBTQ rights or for the larger community. And so I think when we look at it as just us versus them, that level of sensitivity, I think we need to remove some of that and just recognize that people who are being harmed kind of consistently and being oppressed consistently, we should kind of be responsive to their needs because not only does it help them, but ultimately it helps us as well.
Well, I could have this conversation, for hours with you, but I need to take some of the questions from the audience as I promised. So we've got 3 or 4 good questions here, and I may try to. I'm going to talk about one question, and then I'll give you some of the other ones because I think there may be some overlap in some of these. So one of the questions that came in is, could you discuss the difference between disparity and inequity? And maybe if you might want to try to tackle that in the context of a question that was raised, what role does access to different kinds of health insurance play in this? Whether it's private insurance or Medicaid. So I don't know if we can tackle 2 of those questions together.
We can, and I think I'm going to tackle the disparity versus inequity question because that is my favorite thing to talk about, and I think that the question is teed up for me perfectly, and then I will pass it over to Stephen to talk about insurance, which I think is teed up perfectly for him. So a disparity is any difference in health outcomes that we see. And it could be because of race, it could be because of ethnicity, gender, where you live, your age, and any number of things, but differences in population level differences in health outcomes. And inequity is a difference in health outcomes that is the result of systemic, avoidable, and unjust social and economic policies and practices that impact outcomes. So a disparity is not really defining what the cause of the difference in health among these population groups is, whereas the inequity is specifically clearly saying that it is the result of unfair and unjust social and economic policies, practices, and conditions. The reason it's really important to distinguish these 2 things is because when we talk about disparities, as we do in the United States all the time, when we talk about differences in health outcomes, we have the tendency, and again, the Surgeon General did it, many other people do it, we have the tendency to think individually or to think in a population group or to internalize the driver of the difference. So we may say that that particular group has an issue. That particular group has a difference because, for instance, African Americans may have lower rates of access to mental health services because they have greater stigma around the mental health system. And so if we think disparities, we tend to think internally, we tend to think individually, and we tend to think of kind of pathologizing on the patient level or on the individual level. If we think about health inequities, we're really thinking about structural problems and structural causes for why we see these differences. And so when we're talking about an inequity, we're really talking about African Americans access mental health services at lower rates. But the reason that we know for that is because it has to do with cost, that health services are very expensive. Mental health services are very expensive. And so cost is the main reason that people don't access, that African American people don't access services. So that's a structural problem. That's a social and economic policy problem, not an internal intrinsic belief system problem. And so most of the differences, I would venture to say 98% of the differences that we see in health outcomes among populations are much more because of the structural explanations, including systemic and structural racism, than it is because of personal choices, cultural beliefs, biological or genetic differences, which is the ways that oftentimes medical and health professionals are taught to think about these things.
And there's an absolute, overlap, obviously, when we have discussions about inequity with access and affordability. So, as was mentioned, and when we talk about health coverage here in the U.S., I mean, if you don't have access to insurance, don't have health coverage, again, how can you truly get your needs met? And we do know that the Affordable Care Act did at least kind of somewhat improve access for racialized minorities. So it did improve access for Hispanic and Latinx communities, African American communities, and our indigenous populations, but recognizing that not all states expanded access to insurance through the Medicaid program. And so if we look specifically, we talk about COVID-19, especially last year, as we were looking at those states in the top 10 of that list in terms of COVID cases and COVID deaths, many of those were southern states. And many of those southern states, again, limited or had limited access to insurance coverage through access through Medicaid. And so there is that overlap. So yes, you may have a pre-existing health conditions. Yes, you may not have had access to insurance coverage before the pandemic. Now we're in the midst of it. So how much of a challenge is it going to be now for you, again, to engage in a way that you need to truly access the supports and services for mental behavioral health and also physical health conditions. So yes, again, we don't want to segregate those conversations and topics because they're incredibly important. But again, out-of-pocket costs for healthcare, as we know, are pretty extensive. The other thing is we do know that there is still kind of that imbalance in access for health coverage for physical health conditions versus those that we see for mental and behavioral health. So we're still trying to achieve parity in a sense. So still trying to achieve the same type of access to not only psychiatric services, psychotherapy services, recovery, and other support services for those communities. So it oftentimes does limit us significantly. And that's why in our paper, we do kind of talk about that push for kind of expanding kind of insurance coverage and health coverage through expansion of Medicaid. We also kind of discuss other ways, especially in terms of this emergency response. So the testing, hospitalizations, and care provided for those individuals with COVID-19 is covered under those emergency funds. But those needs for mental health conditions are not funded. We know that people have the potential to have disordered grief as a result, a trauma response, other psychological sequelae like depression or anxiety related to those conditions. because they've either been impacted directly by COVID-19 or had the loss of a loved one with it. So what are we doing to prepare ourselves to meet that need after people have kind of recovered and survived from COVID-19 and are still here, but they're struggling with some of the mental health concerns as a result? Who's going to pay for, provide, and support that care when we still have large gaps in insurance coverage for our communities?
So keeping in mind the time, because I want to give you an opportunity for a closing comment, there's one other question that I think, taking in your response to the last two questions, that poses this question about what are models or frameworks to evaluate system level change. And I know that for a lot of people in the audience, the word evaluation is loaded in white privilege, white norming, but I think it's important, because I think that at some level we will have to do systems level evaluation. I think if you think about it, we will not get to where we need to. We will not get the funding that is needed, without some discussion about how measurement looks. So I'd be curious, forcing you to, be succinct on this because of time. What are your thoughts on evaluation at a systems level?
I think this is a very challenging and not a question that I can answer succinctly.
Well, go ahead, and go ahead and
I'll do my best. But I do think, Joe, you're highlighting this important part about how the way that we typically think about frameworks and evaluation is through this lens that is very limited in its scope, and it is set up that way. It is set up in a non-syndemic theory type of way. And so we're asking people to think about and evaluate and see progress with the syndemic approach, but yet our evaluation systems are set up to be very reductionistic. I'm thinking in terms of like the NIH and NIMH and NIDA, like these research and evaluation in these settings is really about trying to come up with one variable and look at that one variable and see if that one variable leads to this one outcome change. And what the whole point of what we have been talking about is that these things are so complex and so multi-layered that if you're making improvements, if you're changing for the better, if you're seeing these outcomes change, it's going to be in so many different spaces and places that aren't kind of are the rates of depression going, I think it's going to be very complicated to try to know what does this intervention lead to this outcome. We can't really do that. So I think that from my perspective, the idea is to look on the whole at, are we actually making progress towards eliminating mental health inequities? That is kind of what we're looking at. So, can we eliminate inequities? Can we set up a system in which we see those gaps closing, especially considering the fact that we've had inequities since the beginning of time, and all of our attempts to try to address them have left us with really no great progress in this space. So the work, I think, has to be trying to think about, we have to ask different questions and answer our questions differently than we have previously. So I'm advocating for just doing something completely different, and I'm not even sure what that is.
Well, I think you just answered it pretty succinctly. I think that there's a takeaway there that we can all practice. So, Stephen, do you want to add to that?
Say no. I think she said it all there. That's a great response. Okay.
I guess it's, in the 5 or 10 minutes that we have left, that we had a conversation about what do you want to leave us with? What's the takeaway that Stephen and Ruth want us thinking about in the days and weeks to come, so that we're all better for this hour that we've spent together. So I'd appreciate kind of hearing from the two of you, what are some of those simple takeaways that I, Joe Pyle, can, internalize and work with, and that the other participants here today could put into their toolbox.
So, I can start and say that I think that we have to completely transform the way that we've been thinking about these problems and the ways that we go about addressing them. And so I think it requires a lot of self-reflection, a lot of time spent looking at how we're operating, the systems in which we operate, and how those systems, how our individual systems, our individual clinics, wherever we're operating, wherever we're providing services, how those services, what are they doing to advance equity and dismantle structural racism in the name of trying to improve outcomes for everyone. And it requires kind of one understanding that our system is inherently designed by design to be inequitable. The system is working the way it was designed to work. So how are we contributing? And what is one or two things that we can start to do to fight against a system that has been designed to harm individuals? And so each person can kind of do an inventory of their setting and begin to start to say, what is a small piece that I can do? What is a small policy change that I can make that moves us in this direction? So that would be my thought.
Yeah, and I'll kind of follow up on that in terms of thinking about that at the individual level. So what can I do? Thinking about that with your organization or institution, thinking about states, municipalities, what can they do? And I think the easiest response I'd have is how would your community kind of grade or rate your response to their needs? And so kind of getting yourself out of your box within your health system, within your organization, to really kind of connect and effectively partner with your community and to get feedback from them on kind of what appropriate response, kind of how to appropriately engage and connect, and how to really and truly serve their needs and their interests, so that it's not so kind of directed within these health systems, again, that seem to be sometimes deaf or kind of disconnected from the individuals around them. So in those communities where we see the disproportionate impact of COVID-19, how we're really responding. The other thing that I would always say is thinking about kind of diverse representation in leadership. So in kind of in administration, in executive offices, on boards of directors, boards of trustees, where are the community members who may be missing from those positions of power and those positions of leadership, and how can we effectively engage them? And then thinking more kind of prescriptively just about our workforce itself and those professionals engaged in treating mental and behavioral health. How reflective is that of your local community in terms of numbers and in terms of representation? And if there is that disconnect, we know that those types of professionals tend to work in their communities. Again, how can we better, one, increase their numbers, but how can we better position those individuals in positions of leadership to kind of effectively kind of connect with and help transform organizational culture or systemic factors?
Well, I wish today was part one of the 8 recommendations. Unfortunately, you all have, lots of other demands beyond the think big or do good policy series. But I think that, your closing comments there on, how do we do an inventory of our setting and the settings that we live and work in and interact with, and how, to build on, your comment about inequities across those 8 recommendations. I think that would be, good advice for us all to head on to that work. I don't know if there's anything else you want to add before I thank you both for being part of this. I know it's an honor and a privilege to spend time with you both, and I thank you for the work you're doing in other places as well. So I want to thank you for that.
Yeah, and I certainly appreciate the invitation. Obviously, always a pleasure has been a pleasure to work with Ruth, but also to thank you for the work that you're doing with this. Think bigger, kind of do good. Just this idea of your core foundations kind of coming together, I think is a great kind of model for others. So thank you.
Well, one thing, in wrapping up that I want to talk about a little bit is that this paper has really led the foundation to be, thoughtful about other webinars that we should be doing in the policy series. And we have two coming up, one on growing peer support, specialized services at a time of crisis, really looking at the use of peers in the mental health system, which I think is going to be a powerful discussion, and enhancing the capacity of the mental health and addiction workforce. I think we have real workforce issues to deal with. But the other thing that I want to highlight before we end today in the minute that's left is that I'm really excited that this policy series and this particular paper is going to kick off for the Scattergood Foundation an exciting new grant program, which will be called Policy Meets Practice, which will support grassroots organizations that are doing work that relates to policy discussions that are being highlighted by the Think Bigger, Do Good policy series. The goal of this program is to bridge the gap between policy and practice in order to recognize and support the bidirectional relationship between policy and practice, where policy can drive practice and practice can drive policy. The first cycle of this grant program will focus on this paper that you've just heard today, that we've discussed, and will take place here in Philadelphia. We'd very much like to be doing this on a broader basis, but for now, it'll be focused in Philadelphia. It'll be focused on organizations with budgets of under $1 million that are doing the work to connect, inform, and advance policy conversations about COVID-19, structural racism, and mental health inequities. The grant program will specifically focus on organizations led by Black, Indigenous, and people of color. It is our hope that this work will have practitioners influencing policy and looking at how policy can influence their work. In the chat, I think there's a link to the registration that will also offer a webinar, informational webinar on March 11th at 11 a.m. Eastern Standard Time. So again, I want to be respectful of your time. All of you on the chat, on the webinar, I want to thank you for participating today. And Ruth and Stephen, I look forward to talking to you again in the future. And thanks for a great dialogue today. Thank you very much.